Thank you, David, for that kind introduction and for the invitation to be here with you this week and have the opportunity to get exposed to and hear about the different kinds of things that are going on around the university. It was a real privilege this morning to be in the surgical ICU with Dr. Hiram Polk and have that experience of one of your great mentors. I think actually the case today that we'll talk about actually made me, some of his points today on rounds made me think of this case a little bit, and I'll tell you a little bit about why. My hope is that this will be very interactive, so I hope that you will engage me in some conversation because I'm really interested in your perspectives on this question. We'll talk about disclosure of medical errors. And before we begin, I just want to get a show of hands. How many people have been involved in a medical error? Okay. And how many people have actually witnessed a disclosure of a medical error to a patient or a family? Okay. Can someone just say a little bit about how that went? Was that did you think it was done well? Was it a good experience? Sure.
That was when I was a physician working for a local hospice, and the error in this case was a patient error where the patient got 10 times the amount intended dose.
How many times the amount? 10 times. Okay, so just because we're recording this, I'm just going to repeat a little bit of that. So it was an error that occurred in a hospice setting where the patient actually received 10 times the appropriate dose. And so who actually, and was the patient in a hospice facility or was home hospice?
It was in the facility.
And so who disclosed that error?
Well, it was a joint thing. The nurse very quickly realized what she had done and informed the physician, and then together they went to the family to discuss what had happened and what the best course of action would be to take given the circumstances of the patient. I was not the attending at that time. So.
Right. Okay, so just also for the purposes of the recording, the error was disclosed by jointly by the nurse and the attending physician once it was realized. And how did the family, was it a harmful error? Did it result in a hastening of the patient's death, or were there any consequences to the medication error?
The decision of the family ultimately was not to have any Narcan or reversal of the medication, but the patient did not experience any adverse effects, and the family was very happy with being informed. So, and they expressed that.
Great. So it sounds like it went very well. The family was satisfied. Presumably the nurse and the attending physician felt like they did the right thing, and everybody was happy about it, and there weren't really some significant consequences to the patient. Yes?
And then the other part of that was, this is what we're going to do now to, try not to have this kind of thing happen again.
Great. So what you're raising is there's an opportunity that comes up when the error occurs, and that is an opportunity to take a step back and reflect on why did this error happen and what are the systems that we can change or that we should change in order to prevent this from happening in the future to future patients, which is a really, really important point. So what I want to do is we'll start with a case for discussion, talk a little bit about the definition of what we mean by a medical error. I want to review some of the empirical data on disclosure of medical errors, because even though we've just heard what sounds like a disclosure process that went very well, there's a lot of controversy about how to disclose and whether disclosure is actually a good thing or a bad thing for the medical team, for the patient in some circumstances, for the family. And then we'll talk a little bit about an approach to disclosure with my hope being to give you really some very concrete tools and skills that you can take away when this happens. Hopefully it doesn't happen, but we know that it does, right? We know that everybody is human and that errors do occur. And so really having given some thought to this process in advance will hopefully help you when you encounter this at some point in the future, or whether it's for you specifically, or whether you're mentoring a student or a resident where an error occurs. And then we'll talk a little bit about some of the literature on disclosure and legal liability, which is one of the big concerns about disclosing and the controversy around disclosure. So this is the case of a code in the scanner. The reason why this case came to mind is because this morning when we were on rounds in the surgical ICU, there were multiple times where what I will call Polk's pearls maybe came through, in which he really pushed the residents to really be thinking, did you really need that CT scan? And what's the trade-off in this balance between getting that CT scan and taking the patient to the scanner and the information that you might gain by doing that versus treating the patient directly and maybe making a decision to just go directly to the OR and not wasting time. So this was a case of a 16-year-old boy who was admitted to the emergency department in shock, intubated and on pressors. He was taken to head CT for evaluation, and he coded in the scanner. Resuscitation was attempted, but it was unsuccessful. And as you're taking him back to the emergency department from the CT scanner, you realize that his central line was disconnected, and he was not getting any of the medications that were actually administered during the code. Of note, the CT scan shows cerebral edema and impending herniation. So my question here is, what do you do at this point? This is a 16-year-old boy. He's got family in the waiting room in the emergency department. What do you go and tell that family? Yes?
You always tell them the truth.
You tell them the truth. So what's the truth here?
Well, that can happen in the middle of a code, somebody doing something, more than one person. They can become disconnected. May not, it didn't have any reason. It had nothing to do with what I got there. And if they correct it right away, it's going to do well.
So let me just repeat this for the recording. So the gentleman said that what you want to do is tell them the truth, and what I'm understanding you to mean by that is that you explain the details of the fact that the central line was disconnected, and that despite the fact that we attempted to resuscitate him, he didn't receive the medicines that we thought we were administering, and that sometimes happens. That this is, it's a hectic time with a lot of people being involved, and the patient's being transferred from the gurney that they were on in the emergency department to the CT scanner, and something may have happened during that process of transfer perhaps. You didn't say all that. I'm putting a little bit more into some words into your mouth there in terms of the explanation that you might elaborate on about how this could happen in that scenario. But you're saying fundamentally you tell them the truth, and that we tried to resuscitate him, but the line was disconnected.
He went in the code before any of this resuscitation started, so it wasn't just starting the resuscitation, he got in the code.
Okay, so because he coded before the resuscitation, what are the implications of that?
What they did is the line coming undone had nothing to do with what I coded. They didn't put the line into last.
Right. Okay. So the fact that yes, he coded. His code was unrelated, presumably, to the central line being connected. Other thoughts on what you would tell the family in this situation? Anybody else have other thoughts? Yes.
Do you emphasize that even if the code had been successful, that it really wouldn't have made much difference in the overall outcome?
Good. So one possibility is that maybe even if the code was successful and the central line wasn't disconnected, that it wouldn't have made a difference in the outcome. So why do you say that? Can you elaborate a little bit on that?
The CT scan showed he had cerebral edema and impending herniation, which means he would have been brain dead anyway.
Okay, great. So because the CT scan shows cerebral edema and impending herniation, it's possible that this wouldn't have made any difference to his survival anyway. So can you just say a little bit more about, well, what are the implications of that for how you would then communicate with the family?
I guess you would just want them to understand that the relationship between what happens when someone codes and when someone is brain dead, that even if you successfully were able to revive a heart, that it's not going to make a difference in the long term. Because I think families would confuse that. They would think that if he coded in the scanner and you weren't able to intervene successfully, that somehow that would have something to do with what happened in the brain.
Good. So the concern is that this can be very confusing to families that are not medically savvy and aware, and to try and clarify this distinction between coding in the scanner and what the cause of his coding was, and your inability to resuscitate him because the the fact that he did not get the medicines because the central line was disconnected can be very confusing to families. So are you suggesting, though, then, because of that confusion and our concern that families just won't get it, that maybe we shouldn't tell them that the central line was disconnected?
No, I think that's confusing the issue because there was an error in the sense of the line was disconnected. We were trying to code him, or we were trying to resuscitate with ACLS. So we obviously were trying to use that line, and we're unaware that it was disconnected. So in that moment, there was an error. The after fact just so happened that his CT scan showed that it wasn't going to matter anyway. The two things are kind of unrelated.
Good. So there was an error, but they're unrelated. So that really forces us to ask the question, though, if there was an error, but it was unrelated to the ultimate outcome of the patient, should we be disclosing that? Should we be disclosing all errors that happen, or only harmful errors? So let's just get a show of hands. How many people think that we should be disclosing all medical errors to patients? Nobody? Yeah? A couple? A couple?
I think there's a third category.
Yeah.
Having uncorrected errors is different from all errors as well. So if I make a mistake but I correct it, or if there's, some sort of documentation process in my particular institution, whatever, that is totally different from, well, I'm never going to tell you anything, or I'm going to tell you everything, even though it didn't really affect anything.
Okay, good. So, for example, I write a prescription, and the prescription is I write the wrong dose.
Right.
It's not that it was misread. I actually wrote the wrong dose of the medicine, but I catch it before the patient takes the medicine, or before it's even filled at the pharmacy. So, if I catch that error before it actually has any effect on the patient whatsoever, well, then maybe that's an error that we don't need to disclose. Is that what I'm hearing?
Yeah, in that case, it would be more like you hand the prescription to the patient, and before they actually walk out of your office, you go, wait a second, pull it back and go, you know what, sorry, I made a transcription error. Either correct it or write it. So
in that case, you're disclosing it. And in those cases, there's very little to be lost, I think most people would say, from disclosing it even, right? But the downside, I think, that we would suggest is that if we feel compelled to disclose every error that happens, even if it doesn't result in an effect on the patient, there are so many errors that happen on a day-to-day basis in a hospital setting, in a clinical setting, that we would be spending so much time and energy doing that. And is that really how we should be spending our time? Do patients even really care? Do they really? Is this valuable information from their perspective? Yes.
I like what she said. If I got my family hat on, I don't want to know. Not going to help. It's only going to make it harder. But if I got my lawyer's hat on, I sure want to know.
Okay, so as a family member, you wouldn't want to know, but as a lawyer, you would want to know. And why would you want to know as a lawyer?
Because you can't bring a lawsuit on the basis of what you don't know.
So in other words, if the clinicians disclose this, then there's the opportunity for families to sue, to bring litigation. And that's a good thing or a bad thing?
Oh, it's a very good thing.
As the patient's family, it's a good thing.
The hospital doesn't want to talk about disconnected lines and 16-year-olds dying. They were very generous in settlement.
Right. So I want to distinguish, and tomorrow my dear colleague Katie Watson, and I think it's tomorrow, we'll be talking at some point about this interaction between the law and ethics. For purposes of today, although we'll talk a little bit about legal liability, because I think it's the first thing people jump to when this issue comes up about whether or not they should disclose or not disclose. They want to know, well, what is this going to, how's this going to affect me as a clinician? Am I going to be more likely to be sued? But before we get to that part of the conversation, I want us to really be thinking more about what's the right thing to do from an ethical perspective. Yes? Yep.
Okay. Getting back to errors, I mean, I think some are so trivial as you pointed out. So if my patient gets a lab draw that is intended for another person's blood, no need to deal with that. In a case like this, though, I mean, you're losing an opportunity to correct errors if there's system errors, and another is there's a
Okay, so you're just so that everybody, make sure that everybody hears it and that it's recorded. Your concern is patient and family societal trust in the medical profession, and that if there's the appearance of our covering something up and not disclosing this, then we may further erode that trust that we've already have trouble with in our profession on some level.
That has an opportunity to correct some error, because the next patient who has that issue might be someone who could have been resuscitated.
Right, so then there's a system issue. I would, however, distinguish the question of whether or not, when we're asking ourselves, should we disclose this error, that question about whether or not we should disclose it to patients is very different than disclosing it to the institution, and the institution keeping track of errors and trying to reflect on them and create some systems for responding to them. So there might be some circumstances in which it may be decided that the error should not be disclosed to the family because there is no benefit. It may be very confusing to the family, and this isn't really why the patient died, so it's a little bit of a tangent that is going to lead to litigation where we don't want litigation. But that doesn't mean that we don't disclose to our institution, to our supervisor, to the head of the emergency department, what happened in this case, and allow there to be some kind of root cause analysis of what went wrong here. Why was that central line disconnected? Because it might not have made a difference in this particular patient's case, but there certainly may be some patients who are not impending herniation for whom it may actually make a big difference. And I think that's a really, really important distinction and an important point. Katie, did you have a question? No? Okay, so let's... So I think some of the questions that we've talked a little bit about is, should you say anything to his parents about the disconnected central line? How do you explain the cause of death to his parents? So if you don't focus on that, what do you say to the parents about why this patient died? And then when, if ever, is non-disclosure justified? And I think that's a difficult question, but hopefully we can come back to it. So first, let's just talk about what we mean by a medical error. And this is from the Institute of Medicine, the IOM report, where they describe medical error as the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve a particular aim. And then the Quality Interagency Task Force actually elaborated on this, where they say that errors can include problems in practice, products, procedures, and systems. So they really broadened the focus here to trying to get us to be thinking about how we can change things to prevent errors also. One of the things that I think is really important to point out here is that when we talk about a medical error, it doesn't necessarily mean that there was a bad outcome. The example of catching a medication error before something happens, or even in the first case that you shared with us of the hospice patient, it wasn't actually a bad outcome, but it was still an error. And then oftentimes medical errors are actually unintentional, and very often they're preventable. And I think that that's what we're really interested in, are the preventable errors. We want to figure out which errors are preventable and how can we go about preventing them so that we can improve the quality of care that we provide to our patients. We can further define errors into categories, or separate them out into categories of serious errors and minor errors. So serious errors are errors that cause permanent injury or potentially life-threatening harm. And minor errors may neither be permanent or potentially life-threatening. And I think that, so when we think about which category would this error fall into? Was it a serious error or was it a minor error?
Any other patient, it's serious.
In any other patient, it's serious. But in this particular patient, right, we have to contextualize things, I think.
Still serious.
Why?
Shortened is already going to be very short in life, but if we're labeling it potentially life-threatening, that was potentially life-threatening. There wasn't much life left, but there was a very small amount.
Okay, so there's the possibility that the disconnected central line shortened this patient's life.
It did. All right. He was declared dead by brain criteria. He was declared dead by heart criteria. Therefore, his life was shortened. Not by much. But if that's your definition, it's serious error.
Well, that's, I see some other heads shaking in a different way. What do the other people think?
You don't know how long the fluids have been disconnected. There's no information about the size, of the wet stain, for example. If he had cerebral edema and he was being treated for shock, excess fluids may hasten, his death, and so the disconnection may have been a good thing in terms of preserving life. And so I think there are multiple views on this, and to make, a solid statement, is really not possible. Everything I'm saying is speculation and conjecture, in part in response to a statement that's overly, ambitious, I think.
You didn't give us a family history as well as what the patient had went through before, so we don't know.
The patient was in shock, right?
We got there, but we don't know why. Did they find him in shock? What was he doing before he got in shock?
Yeah, so there was a febrile illness. Basically, the patient was septic. It was septic shock. But frequently, that's the situation in the ED, right? You don't have all the information that you would like, unfortunately. There was.
You got to get it. Somebody brought him in. You've got the information that you see when you look at the patient. We didn't get that. Assuming his blood pressure was bottomed out.
Right. There was a comment in the back.
Well, in the line of potentially life-threatening harm, it's a loss of a chance.
I'm sorry, I didn't hear that?
Loss of a chance.
The disconnection of the central line, you're saying, is a loss of a chance. Okay. And therefore you're saying that's a serious error. Is that what you're putting it in that category?
Yeah.
Okay. Because there was the potential for this resuscitation effort to succeed. I'm not sure that's the case. I think that there's a lot of uncertainty here, and that ultimately we don't really know. But the fact that the patient was herniating really suggests that it was unlikely to have any significant impact, I think, on this patient's survival or prognosis. But I think we need to be asking ourselves whether an error was serious or minor, because in many ways that can help guide our thinking about what we do with that information, what we do with that error, and how we approach families. Yes?
Given the example that you gave of a prescription that the doctor wrote incorrectly,
Yes.
but the patient did not experience that, was that a medical error? Or does the patient have to experience the error, either serious or minor or non-consequential?
Right. So I think that goes back to this definition, and I think that that was, by this definition, an error, right? It was an error somehow in our procedure, or what the planned action was, right? The planned, in that case of the prescription.
It wasn't completed because you caught it before the patient experienced it, thus it was not completed.
Yes, but
if the patient had received the wrong dose, but it was stopped before it reached the patient.
Right. So you could say it wasn't an error. I think there's actually some value to acknowledging the problem in that case, actually, because it gives you the opportunity to reflect on the systems and what happened there.
But the patient actually did not experience.
Right, and the patient didn't experience any problems with it, and I think that that's part of the reason why we would say that it's not necessarily essential that you disclose that you go out of your way to disclose that. I mean, it's possible, for example, I think that the issue that was brought up earlier in terms of trust is an important thing to remember in terms of what are the advantages of disclosing, and that being restoring trust. But if you were able to catch that medication error before it even, before the patient filled the prescription, and you just called the pharmacy and say, I wrote the wrong dose, can you just change the prescription to the correct dose? And the patient wasn't involved in that conversation at all. I don't think anybody would have any qualms with that approach.
The patient wasn't involved in the description of the case that you gave.
Of the 16-year-old in the scanner, or the
prescription that you that the doctor wrote incorrectly was stopped before the patient was involved?
Well, one of the ways we were talking about it earlier, I thought, was that you catch the patient before they leave the waiting room and you say, oh, this is really the right prescription. I made a mistake in how I wrote it. But there's a variety of scenarios. I think that what my goal here is really to get you to be thinking about what is this distinction between a serious error and a non-serious error and a not-serious error, and how does that affect your decision about whether or not you actually should disclose the medical error? That a minor error does not necessarily have to be disclosed, and if we had a policy of every minor error being disclosed, that would be very cumbersome and not particularly useful, and it's not clear the patients would actually want to know that information. So I think that's the main point that I'm trying to convey. So what are some of the reasons, the benefits of disclosing medical errors, and what are some of the harms of it, or the risks involved in disclosing? So I think in terms of benefits, one is just there's this ethical obligation to be honest, right? You want to convey to patients and families the truth. As was said earlier, we should just be telling the truth to patients, so why not tell them? It promotes patient and societal trust in physicians. It may actually decrease patient motivation to sue, but I think that's a very open question. And it's an interesting question that some people think that non-disclosing will actually lead to less lawsuits, but it may actually, by disclosing, you may actually build that rapport with the patient and therefore lead to less likelihood of a lawsuit. And there may be opportunities for quality improvement and improved patient outcomes as a result of a reflection on the problem. So what are some of the risks, though, of disclosing a medical error? Why don't people feel comfortable doing this? I think first and foremost, there's concern that their professional reputation may be damaged, right? If I become known as a person who was responsible for significant or serious medical errors, does that say something about me as a clinician? That somehow I'm not a good clinician because I caused an error. And therefore, I don't want to share that with my colleagues. It's more of the biggest concern may be with my colleagues as opposed to my patients. There may be financial harm if I get sued. There may be a negative emotional impact on clinicians. I think that's huge, actually, and what I mean by here is not just physicians, but nurses also, because nurses are often and nowadays physicians' assistants, nurse practitioners, right? This isn't just a physician issue. This is really all healthcare providers, and I think that the emotional toll that actually accompanies causing an error, the shame that goes along with that, and the challenges of knowing that you actually did something that may have resulted in significant harm to a patient can be very, very difficult for individuals. And it may encourage litigation. So this is just some empirical data by a colleague of mine, Tom Gallagher, who's done quite a bit of research on medical errors, and he looked at who's disclosing medical errors and why are they doing that. And this was a study done in 2006. And they found that 58% of medical specialists would explicitly mention a medical error, okay, compared with 19% of surgical specialists. So those in the medical area were more likely to disclose, but still a pretty significant percentage are not disclosing, and that was back in 2006. I think we may have gotten actually a little bit better. Why do you think that is? Why do you think surgeons are less likely to disclose a medical error than people in the medical specialties?
Patients are unconscious.
Yeah.
Okay, but eventually they become conscious most of the time. Right, or you have families, right?
Different relationship. I think that with someone you're speaking with more, there's a possibility, a different sense of partnership.
Okay, so surgeons may not have the same rapport with patients or families, and therefore may not be as inclined to share this kind of information. Other thoughts?
Well, part of it's character flaw. I could rotation or orthopedics with Dr. Harkness, and he came back and he had taken some screws out of a hip, and he took 3 screws out, and there was one he missed. And the patient knew that. The patient was an engineer, and Dr. Harkness court says you're right, you need to go back. It's not going to, there won't be any charge to go back, and it's not going to be will affect the way the hip works. But then he turned to me and says, you always tell the truth. And I think the most important thing is each doctor, I've been head of the PRC for a number of years. It's just getting...
What is the PRC?
Professional Review Committee. We go after the doctors that don't make rounds and cuss at their patients that slid the 70-year-old, 90-year-old that's in liver failure because the 90-year-old hit him in the emergency room. Now, if you come in and sit down, the big complaint is patients say that a doctor doesn't care about it because he sticks his head in the window. If you go over and sit at the bedside, pat him on the arm, and act like you've got all day, you don't have to be any good, but he's going to tell everybody, or she is, that you're the most wonderful around. So these people are struggling with things that the people that go to the hospitals don't understand what's going on in a hospital. I grew up as a little boy, running around with my father. So I was comfortable in it, but you can change the way somebody feels. When I covered for a doctor who had hip surgery, I was an ophthalmologist before I retired, I had 4 patients. The first 4 patients, I introduced myself, and they all asked me what my father's name was, and I told them. The first patient said, until I married my best friend's husband, I loved your father more than anybody I know. She said, I was told I had colon cancer and would die. She was a young woman. It was the old Baptist. Said that your father, one of my friends asked your father to see me. She said, he sat down. He came in and introduced himself, pulled up a chair and sat on, patted me on the arm. She said, I could feel my shoulders drop. She said, when he left, I knew I'd get better.
So it sounds like you've been the beneficiary of tremendous role modeling, and we'll talk a little bit about role modeling, both in terms of your own father as well as other physicians.
Now, when I saw her, my father died of 67. He was a general surgeon and died of an aortic aneurysm. When I saw her, she was 96 and 650.
Wow. So I think that I think you're right. You're making a really good point, which is that there are many other characteristics or behaviors that we as clinicians need to internalize in terms of how we relate to our patients that make a difference to whether or not, to how they're going to respond to us telling them the truth or not telling them the truth.
And young doctors aren't in that big a hurry. They think they are, but the only person that counts is the one you're standing with. If you make a difference in that life, that person is going to send you more patients than anybody else you ever operated on.
So you're making really, really good points. I want to come back to this distinction, and I think that part of the reason for this discrepancy that we're seeing here has to do also with the fact that there's a greater connection between the error and the surgeon than there is between the error that medical specialists that occur with medical specialists and the physician and the patient. And what I mean by that is that patients in an ICU where an error occurs, in a medical ICU, if something happens in that intensive care unit setting, or there are so many different people involved in the care of that patient that it's very hard to pinpoint an error and say this is you can't point blame and say usually that this is the fault of one person in particular. But when your orthopedic surgeon forgot to take out that screw, there's no doubt that that was his fault. Right? There's nobody else who was responsible for that. So it was a great example, and I think that it's that ability to point a finger and blame someone that leads surgeons who feel responsible and are ultimately responsible to be less likely to disclose an error because they're concerned that it's going to all come back to them. Now the truth is that in the medical specialties, ultimately the attending physician is accountable and should accept that accountability, ideally, even if they themselves did not directly cause that medical error. But that's something we need to engender and develop, I think, because it's not as natural, there isn't as natural a sense of responsibility and accountability in that world as there is in the surgical world. So Dr. Gallagher also found that respondents were actually more likely to provide full disclosure of information if they had positive disclosure attitudes, just like you were explaining. You know, you had a mentor who said, we tell them the truth. He went in there and did it. You witnessed that, and that has a tremendous impact on how you then go on to behave as a clinician yourself. Individuals who felt responsible for the error had a prior positive disclosure experience. So, and I think this is one of the huge problems, is that medical students and residents rarely are included in these conversations. And we really need to go out of our way to include them in these conversations so that they can see how it's done, so that they can know that this is something they should be doing and that it can be done, and here's how to do it in a tactful way. And actually, those that were Canadian. Now, why that was the case, I don't really know, other than Canadians just may be more truthful people than Americans. I don't know. That may have something to do with it. There maybe not. The legal system may indeed have something to do with it. The fear of litigation may be very different. Are you Canadian? Okay. Full disclosure. This was a more recent study from 2007 which found that willingness to disclose errors was associated with higher training levels and generally patient-centered attitudes. So in other words, attendings are more likely to disclose than fellows, than our residents, than our medical students. And that's not surprising, right? Because medicine is so hierarchical that the fear of a medical student admitting a medical error and what effect that's going to have on his or her career is much greater than an attending. And so it makes sense that those at higher training levels are going to be more open to disclosure. And people who had actually previous exposure to malpractice litigation did not lessen, it didn't have decrease a willingness to disclose information. This is from a study that is currently ongoing, and I'm actually looking forward to the University of Louisville participating in this with medical students, actually. And this was a study that looked at residents' experience with medical errors, and in particular disclosure of role modeling. And it was it's a multi-center cross-sectional survey of trainees, of residents' attitudes and experience with errors and exposure to role modeling, in which they were administered an anonymous electronic survey across surgical and non-surgical specialties. And so far this has just been done at MGH and at the Brigham in 2 teaching hospitals in Boston to PGY1 and PGY3 residents. And what we found was that exposure to role modeling is related to attitudes about disclosure, and self-report unprofessional behavior is related to medical error. Exposure to negative role modeling may have a greater impact than exposure to positive role modeling. So we gave residents a series of questions about their exposure to positive role modeling with regard to error disclosure in particular, and negative role modeling, and then looked at the impact that had on their willingness to disclose harmful medical errors. And in this case, we took what we talked about in the beginning in terms of this distinction between a serious or harmful medical error and a minor medical error, and said, okay, we're not worried about the minor medical errors, let's just focus on the harmful medical errors. And it looks like actually having negative role modeling has more of an impact than positive role modeling, and this is actually concerning, I think, because it's harder to get rid of the negative role models than it is to create positive role models, I think. And training house staff on how to respond to medical mistakes is important, but it actually may be insufficient to ensure professional conduct in response to errors, in particular because they may be exposed to these very negative role models. So we've got a lot of work to do, I think, in our hospitals, in our clinical institutions, to ensure both that we have positive role models when it comes to error disclosure, and also that we're getting rid of those clinicians that are not willing to disclose and are not willing to be held accountable and to be honest with patients. So what about patients? What do we know from the literature in terms of what patients want? This was also a study from Tom Gallagher, in which he found that patients actually want disclosure of all harmful errors. They want information about what happened and why. They want information about how the error's consequences will be mitigated and how recurrences will be prevented, right? They want to know that you are thinking about this and that you've come up with some system to prevent this from happening to future patients. And they want emotional support from physicians after an error occurs, including an apology. And I think that this is a contentious issue because many people don't feel they should be apologizing lest they apologize, lest the apology gives the appearance that they are responsible for the error. So what about physicians? What do physicians think about this? Physicians actually agreed that harmful errors should be disclosed, but they quote-unquote choose their words carefully. Right? They often avoid stating that an error occurred, why the error happened, or how recurrences would be prevented. They worried that an apology might create a legal liability. So if I say that I'm sorry that this happened, then they are going to be more likely to sue. And physicians were upset when errors happened, but they're unsure about where to get emotional support. And at our institution, this has actually led to the creation of a Center for Professionalism and Peer Support, where we've trained people to help with disclosure, the whole process of disclosure, and created sort of a system of disclosure coaches. And we've also allowed people who have been involved in serious medical errors to get support from other people that have gone through that and through the whole malpractice litigation process, so that they have someone that they can talk to and can be there to provide some emotional support. So let's talk a little bit about what is required for a high-quality disclosure, because I think that that's really one of the key things that I hope you'll take away from this talk today are some very concrete tools about how to go about disclosing a medical error. And I think the first thing is to make sure that there's some planning with the medical team prior to the patient and family meeting. And the purpose of that is really to make sure that everybody is on the same page, that you're not going to go into a conversation with the family and have the nurse saying one thing and the physician saying something else about what happened and why it happened. So you really want to be clear from the outset about, as much, depending on the circumstances, you may not know everything, and that's okay. It's not as if, sometimes these errors are very, very complicated, and it's not easy to sort out what actually happened, and that's okay. The challenge is you don't want to go into a meeting with a family, especially in a situation where there was a really devastating or tragic error, like in the situation where there was a bad outcome, where the patient died, and give the family the impression that nobody really knows what's going on here, and they're hearing very mixed messages from different people on the team about what happened, because that's going to create a lot of suspicion. It's going to really erode patient or family trust, and you really want to avoid that. You want to acknowledge and subordinate your own emotions. And remember that really the purpose of meeting with the family is to respond to their questions and not to unload all the emotional trauma that you have because of this serious error occurred, because your patient that you were trying to save actually died. But at the same time, you need to acknowledge those emotions and just sort of check them before you go into that room with that family. And hopefully that there are other institutional resources to support you after or at some point along this experience to provide you with some of that emotional support. Initially, you want to really just disclose the facts versus an interpretation of the facts. And I think that this is really critical because these errors are so complex. It's not really clear why something happened. And when you're meeting with the family, it's not a root cause analysis. That root cause analysis may take a week to figure out. You may need to go through multiple charts and talk to many different people who were involved in the care of a patient in order to figure things out. But what you need to do is just sort of say, this is all we know right now, but we're committed to finding out why this happened. To really be honest with the family and let them know this is what happened, but this is also the limits of our knowledge right now, right? The next issue is apology, and I think that the literature tells us, as I've tried to share with you, is that patients want an apology, families want an apology. And I don't think that there's, I hope I'm not disagreeing with any, I don't know what the processes are within your institution, but we've succeeded, at least at our own institution, and I think the literature supports this at a variety of other institutions, in encouraging and supporting clinicians who, and encouraging them actually to give an apology. And what I mean by that is saying, I'm sorry that this happened. It's different from saying, I'm sorry that I caused this. Okay, I'm very sorry that your son died. And we can be empathic and we can be sorry that something happened even if we're not ultimately responsible for that event occurring. So I think that giving an apology is really an expression of sympathy. It's admitting responsibility. It's showing remorse, offering an explanation, and potentially in some cases trying to make some reparations. And we'll talk a little bit more about that. But patients ultimately want sincerity, and they want to know that we care. And I think we all do care. We're just afraid to say that we care out of fear that it may be interpreted as we're responsible. The other important thing is that this meeting with family really needs to be timely. Ideally within the first 24 hours of an error occurring. You know, in the case that we talked about at the very outset of someone who's in the emergency department, there's no doubt that it's critical that someone needs to go and talk to that family immediately. Right? Fairly immediately. You have to really have your act together and pull that team together before you go in there and have that conversation. But it's not something that can wait. Right? This is an emergency department, which is very different than an inpatient setting. And there needs to be some institutional support for that. And I'd love to hear what kind of institutional support exists here for this, and whether there's an attention to trying to do this disclosure in a way that is going to be most useful to patients and also to the institution. Okay, so here's some just summary, some very specific recommendations for the disclosure process. So telling the patient and the family what happened, focusing initially on what happened and leaving the how and why for later. We frequently involve our risk managers at our institutions or people from our ethics consultation service, as they are very adept at facilitating these conversations, but there's no doubt that the attending surgeon or the attending physician involved needs to be included. You have to be very honest and open about the incident and about what is being done to mitigate the injury or prevent a recurrence, and I think that that's a step that may be difficult initially to be aware of and to come up with on the spot. Like, what are we going to do to prevent this from happening in the future? And you might not be able to share that with the family, but you can say, we're going to really take a close look at this from an institutional perspective, and we're going to really try and figure out what we can do to prevent this from happening in the future. And a failure to acknowledge the event can be very distressing for the patient and is also a powerful stimulus to complaint or litigation. I think that's an important thing to remember, that patients own their medical records, and they can have the right to request it. Families can request it. They can review those medical records, and if they discover a serious error after the fact that wasn't shared with them, the consequences of that in terms of litigation and in terms of relationship to the institution, to clinicians, is I think much greater. We need to explain what will be done and what will be done to prevent these events from happening in the future. And this is just more data that shows that patients actually have a strong interest in knowing what happens and what happened to them, and that it won't happen to someone else in the future. And it helps patients see that some good may actually come out of their experience, right? So even if something terrible happened to someone, the fact that that event will lead to a benefit to future patients is actually very comforting to many people. And so I think that we'd be remiss if we didn't put it in that context. So let's talk for a moment about non-disclosure and legal liability. This is just some initial thoughts about saying I'm sorry and this question about whether or not it's going to prevent a malpractice lawsuit. And this person was suggesting that actually when errors are not divulged by the physician and are discovered later, patients are likely to become angrier because they felt that something was being kept from them, that you were trying to cover up something or that you were hiding something. And patients in this kind of setting are more inclined to file a malpractice lawsuit. And it's also one that is more likely to result in a higher than average settlement or a jury verdict. So this is one perspective. I think that I'll just sort of tell you where I'm going with this, is that I think that there is the jury is really not out on this, I think, yet, and there's conflicting data on whether disclosure from a legal liability practice helps or doesn't help. There is an approach that I think has been shown to be very helpful, which I'll show you at the end. This was from another study in which the fear of lawsuits was cited as a significant barrier to disclosure for many physicians. But yet there were some surveys that indicate that patients are actually more likely to sue if they perceive that disclosure was absent. So again, there's some data that suggests that hiding this is worse. And this was a 2004 study that asked patients whether disclosure of an error by their physician would influence their decision to seek legal recourse. And 49% indicated that they would sue if there was no disclosure, but 51% said they wouldn't. And full disclosure by physicians only reduced this percentage modestly to 38%, so from 49 to 38%.
Lisa, this was hypothetical.
Yes, this was hypothetical. This was some data by David Studdard and Michelle Mello, which was a little bit more, I think, suggested in the opposite direction of some of what we've seen, which is that the initial reaction of patients to disclosure is likely to be a gratitude for honesty, but then additional reflection they found actually could lead to negative feelings. And one study that they were involved in indicated a 95% chance that the number of lawsuits would increase under a full disclosure policy. Okay, so there were some concerns here that full disclosure would lead to an increase in litigation. But then there was another study that found that forecasts of reduction in litigation volume or cost did not withstand close scrutiny. So the reality is, I don't think we really know the answer to the question of whether or not disclosure reduces litigation or doesn't reduce litigation, or increases litigation. Okay, that's the concern. But the University of Michigan undertook a very interesting study, which I think was does really shed some very interesting light on how we might approach this. But it goes beyond disclosure. And what they did was they did a comparison of liability claims and costs before and after implementing a disclosure with an offer program. And what I mean by that is that they immediately offered remuneration to patients where they felt that there was a harmful error that occurred that they were responsible for. So they said, well, you know, don't even, you know, we don't want to go down a whole big malpractice lawsuit. We just want to offer you a settlement. We recognize that we made an error here. We acknowledge it. We're sorry that we did this. This is what we're doing to prevent it from happening again in the future. And we want to give you some financial reimbursement for the harm that you have that has occurred to you. And what they found was that the average monthly rate of new claims significantly decreased. The average monthly rate of lawsuits actually decreased. And the average monthly cost rates decreased for total liability and patient compensation and non-compensation related legal costs. So this process of not just full disclosure, but disclosure with some kind of remuneration, or what they call an offer program, seemed to have a significant effect on decreasing litigation and costs, interestingly. So just in summary, I think what I hope to have communicated is that it's really important to be thinking about disclosing medical errors, and that serious errors should be disclosed to patients, and that fear of litigation is actually not a good reason not to disclose it. And that hopefully, as an institution, there can be some system in place for dealing with the disclosure of medical errors that can support clinicians as they approach this, and have some kind of process for interacting with patients to decrease the likelihood of a legal lawsuit. Honesty is actually not enough. I think that what we really need here is we need to be truthful with our patients, but we really need excellent communication skills. And we really need to be thoughtful about how we approach medical errors with families and patients. We need to have a process in place for doing this, and we need to be good at communicating. And I think that there's an interesting opportunity to really change the paradigm of what's shared with patients and families here, because we've had a system in place where families and patients are really not aware of a lot of things that happen on a day-to-day basis. But here we have an opportunity to really change that and have a much more transparent relationship with patients and families. But in order to accomplish this, we really need positive role models. We need attending clinicians who are willing to accept accountability for an error, to admit that it happened, and to demonstrate how you go about communicating these very difficult things to families. And I think that the other thing that we learned from the University of Michigan study is that there are institutional benefits to a policy of proactive disclosure with compensation. So not waiting till the family sues you, but saying, before you even go down that road, we're going to compensate you. That may actually lead to much less legal costs and I think a lot less trauma for clinicians also. So I'm going to stop there. I'm happy to take questions. I'd love to hear about your experiences and what's being done in the institution and in terms of how to deal with errors and whether there's been any consideration of this proactive disclosure with compensation approach.
Well, the language that you've used has gone from serious versus minor to Gallagher used harmful versus minor. Now we're back to serious. The concern that I had with the definition of serious was that it isn't the same as harmful. Something can be serious under that definition and not harmful. The case in fact, the case in point in fact, was serious under that definition and harmful. We want harmful as the definition that's important, not serious.
I think you're right about that, and that distinction between serious, the serious and minor, you know, this is an evolving field, and that some of the language that's used in some of the earlier reports on this and some of the earlier surveys may have been that, but we've actually moved to talking about this in terms of harmful errors now. And the recent study that I showed you with residents looking at role modeling and their experience with disclosure focused specifically on harmful errors.
My question is concerned about the gray areas of what is an error. Specifically, let's say a doctor orders a genetic test for somebody without that person's consent, then receives information that test could be harmful to their future or to their children's futures. Do they have the duty then to tell the patient about those results?
So that's a great question. Just let me repeat it so that everybody can hear it. The question was, if someone does something that is potentially harmful but they don't realize it when it occurs, like ordering a genetic test that may have implications for other family members, is there then a duty to share that? And I think that the answer to that is yes. Actually, I mean, the case that you gave, the interesting example of a genetic test in particular, in Massachusetts, you're actually not allowed to order a genetic test without written informed consent. And it's precisely for that reason. And it sounds kind of crazy. I actually don't think it's followed in practice for the most part, and I don't know what the policy, the requirements are in Kentucky with regard to that. But it's precisely that concern that somehow genetic testing is a little bit different. And you better be thinking about the implications of this genetic test, not just for the patient in front of you, but for all of those patients' blood relatives. So there needs to be some thought to that. But if you discover that, yeah, it seems to me that it's very reasonable to go back to that patient and say, you know, I was remiss in not discussing this aspect of this genetic test with you.
I was curious, so I'm interested in this definitional question, but even if we say harmful, there's minor harm and major harm, and you know, we could still have to split that. And I was interested in the study, I think it was the one that Wendy Levinson was on, that asked what patients wanted. Right. And it said they did want harmful error disclosed. I wondered if they were asked about, you know, minor harm or. They were. I think they were. I'm pretty sure. They don't. That was the point of that. The patients don't want. They don't want to be bogged down by it. It doesn't make a difference to them. And there's an assumption, I think, that errors occur, and if they're not harmful, if they don't have any consequence to me as a patient, then don't waste your time and don't waste my time.
But if they have a small consequence.
Obviously, there's a judgment there.
It's a question because as a doc, I can imagine the sort of like, that's small. You're going to take some pills per week. You're going to be a little uncomfortable, whatever. Versus as a patient, you're like, I would have been fine. I want to know why I'm taking that medication. So I just was interested in I think there might be a lot of debate there of what's impact.
Right, and I guess I mean, I think you're raising an interesting point about whether or not clinicians will try and use that data to then say, well, I don't have to disclose this error because it really wasn't harmful. So I think you're right. There's a judgment involved, and it's not entirely clear. We haven't sort of decided which errors are definitely harmful. There's some that are clearly harmful. We can say they result in significant injury to the patient, death. Those kinds of things. There's that one end of the spectrum, and there's ones on the other end of the spectrum which are clearly very minor and inconsequential. And then there's this gray area, and the question is, what do we do with that gray area? And part of the issue here is getting clinicians to be more sensitive to this whole area, so that they can go back to some of those reasons why we should be disclosing medical errors, and remembering that there's another value to just being honest with our patients and to the trust that we're going to be able to engender.
And I just want to offer one follow-up comment also with this compensation model. I think in real life, in normal human interaction, apologies usually include making someone whole if you have caused them harm. So if I break an expensive piece of china at your house, if I say, Lisa, I'm so sorry, that gets me halfway there, but offering to buy you a new plate usually follows to make you whole. So the concept of making someone whole and saying we're going to cover your medical expenses, you missed work for this, we're going to pay it. It sounds like some radical medical legal solution, but I think it's what we do if we were at each other's house for dinner and something went wrong.
Yeah, it's a good point. So the idea that it's very reasonable to offer some compensation where an error occurred. The challenge is, though, how do you make someone whole when you've caused the loss of their life, right? And can we quantify that in financial terms? That becomes very challenging to do. And are families going to be willing to rely on the institutional assessment of that value versus going through the legal system? It's an interesting question. Yes?
I was most interested or most intrigued, I guess, by the professionalism and peer support, because oftentimes when you make an error, what happens is, let's say, if it's an inadvertent error, you may make it and own up to it and whatever, but then, maybe a month later you get this, it's not an anonymous letter, but it's a letter from someone that you don't even know, because they're a colleague, but they're not a colleague because you never see them. They're an administrator, and they sent you this letter saying that, oh, by the way, you'll appear before this committee, and it feels very aversive rather than supportive from, administration versus the caregiver involved. So I mean, that's really interesting.
So, and I'll just say that our peer support is done by clinicians, and maybe that's the difference. It's not an administrator within the institution. There's some administrative support for it, but really it's trying to connect clinicians to clinicians who have had similar experiences and who are going to be empathic and really understanding what this person is going through, especially if there's a lawsuit that's ongoing, because that can be really traumatic for clinicians. David?
I imagine you have opportunities in medical school and in residency program to teach about medical error. How do you either responsibly or proactively try to undo the hidden curriculum of those negative role models, those ne'er-do-wells will say, don't ever, unlike Dr. Edelin, would say, don't tell the truth, you'll just get sued. How do you undo that, or how do you immunize against it?
So the question was, how do you undo the negative role models or immunize against it? I don't have a good answer to that. I'd love to hear your perspective on it, or if anybody else has thoughts about how to overcome the impact of those negative role models. I think that we can be proactive in terms of trying to educate people about why we should be disclosing, how to disclose, provide them with support institutionally and emotionally to do that. But that's the positive role modeling. And then the question is, will that positive role model, and I don't think we do enough of that. So I think that's the important point, first of all, that we don't have enough positive role models, and there isn't enough exposure, I think, amongst medical students or residents about how to do this and how to do it well. So we have the opportunity there to build in that positive realm, but as our data suggests, that's not going to overcome the impact of the negative role modeling. And I don't know how you get around that other than other clinicians calling those negative role models on it when they see it. And other leadership within the institution acknowledging that this, the way you handled that is really not right. Another possibility may be some kind of anonymous reporting system that will allow people without concerns about a threat of, their career or the fellowship that they want to get into, those things won't be affected if it's done anonymously. But I think the reality is that even those anonymous reporting systems don't work that well because teams are so small. And people know, if you have a senior resident telling you as the junior resident or as the intern on a team, don't tell anybody about that. And I know that happens, actually. It's very hard for that intern or junior resident to go above that person because they know that person is filling out their evaluations, and especially if it's an attending and not even a more senior resident.
So now we have for ethics committees the ability to seek a consultation if when you try to discuss it amongst your team, there's intransigence by the team, by the attending, about an ethics issue that's come up. And it sounds like what is necessary is some sort of way in parallel, the way that you can have a resident or a student ask for an ethics consultation, that a medical student or a resident should be able to seek advice from some peer review type committee or from legal counsel about inappropriate legal conduct, because it exposes everybody. It not only exposes the attending, it exposes the hospital, but also the residents, because residents can get named. So there's some skin in the game for the medical institution to actually respond, rather than just saying, oh, boys will be boys and girls will be girls, don't go ahead and give them a hard time.
Yeah, I think you're right, and I think that there are those systems in places, that there are places where individuals can go to seek that kind of advice, both through the ethics consultation service. I mean, we have had questions about disclosure of medical errors that have come up to our ethics consultation service. And the other places, our risk management office, our legal office, those questions can be addressed there. But the real question is, are medical students and people who are early on in their training going to take the risk of doing that?
Right.
And I think that the real question is whether or not we can do something within the culture of our institutions to make it safe for people to do that. But I think too many people are saying to themselves, is the trade-off worth it? Is it worth the risk to my career to disclose, that this person didn't, that this person caused this error and didn't disclose it, and it was a serious error? Or should I just shut up about it and move on, and I'm going on to my next rotation and it doesn't matter? So there are very few people who I think are principled enough and have the moral courage to stand up and go to seek help in that kind of advice in that kind of situation. And I think it really goes back to the training of our medical students on some level, in terms of empowering them more generally to have that moral courage to speak up when they see something that's wrong.
And to sound like a total economist, maybe set up some incentives to help counteract the disincentives, right? Obviously the disincentives are pretty big and hairy: reputation, career, hierarchy, right? But they're also very abstract. So how concrete could you make some of the incentives? I mean, obviously you don't want to do the $50 for everybody who discloses a problem, because those are problematic in and of themselves. But within the curriculum that you're developing, within the training that you're doing, what about positive incentives as well as calling out the negative behaviors?
Good. So the suggestion was that we should create some positive incentives to encourage people to disclose. And so I'm wondering, do you have any thoughts about what those might be?
A lot of it is going to depend. People are motivated by different things. So I hesitate to do everybody just needs this. But since what you're dealing with are so abstract, what about, well, we're going to promote this person who does have positive role modeling experience over this one who doesn't. Make it a categorization for promotion so that you address the hierarchy. Make it a part of the selection process for any time you're handing out better assignments. And then make it known, make it discussed that this is one of the criteria we're using. So not only are you building it into the curriculum so that students know there's this expectation, but you're starting to build it into the actual processes that surround people, so that it affects reputation, and it affects hierarchy, and it affects career.
Right, so part of our assessment of an excellent clinician has to go beyond clinical outcomes and should take into account these kinds of behaviors. I think that's a really, really great point. Yes?
This is part of when you're building your career and your reputation. And if you start off standing for what you would do for your child or for your best friend or something like that, you start off with that, and that's over time builds, and that carries into your practice. I have patients follow me from general hospitals in my office when I open up the practice. Don't be afraid. I mean, that a physician, that's who you're supposed to be. Somebody who stands up for those who are unable to do it. And I never had a mentor. I had one mentor, it's a short story, in medical school. I was a freshman the first time I was in a hospital on the ward. My first patient had upper GI, lower GI. He was African American. He had been strong, but he was bleeding out. And the fellows came down because they wanted to draw a lot of blood to put it in their freezer so they could write up something and publish. And they came up, and I had kept track of all the blood that they lost and what he'd taken when they came up to me. I said, no. And they said, what year are you in? I said, well, I'm a sophomore. I mean, a junior. It's my first rotation. And they went back and told the head of infectious disease, who later came back. I said, I'd like to make the diagnosis, but this is what he's lost, and this is what he's transfused, and I'm going to get him out of here one way or the other. And you can't have any blood. The head of infectious disease came down and said, and asked where the medical student was, and I got right in his face and told him he couldn't have any blood unless he talked to the head of the Department of Medicine. And for 30 years, he never spoke to me. He walked by, he lowered his head until one day he came into the PRC committee when I was chairman, and he had to speak to me. But I didn't start medical school until I was 30. And I'd lived with doctors, and I'd seen what I would call the golden age of medicine, where all these doctors adored their patients and would do nothing but it. And I knew I was right. And
I don't know if I'd call that the golden age of medicine. Okay.
Over here.
Yeah, go ahead, Katie.
Oh, I'm sorry. Just quickly, it's interesting. It seems to me that the issue is it needs to be normalized. And so looking at the, you can just read the statistics about how much error happens. This shouldn't be an unusual thing. And so there's the valorizing it thing. And so one question I have is at your institution with this new center, are the folks who are the peer counselors, are their names prominent? Like the idea that it's a thing of esteem to be a peer counselor, and that we see esteemed people are doing it, so therefore we know they've had an error. That seems like one laudable way to give it almost status. But the other thing is, I'd love to see a performance review of just like, tell me about the errors you've disclosed this year. Like that it's normalized. If you haven't disclosed an error this year, something's wrong, because we know statistically speaking, everybody's
had them. Yeah, that's an interesting point. It's a good point.
Part of your performance review.
Right. Has anybody ever had that be part of their performance review? No? Yeah. Good.
This was kind of where I was going with that. And this is the flip side, and that has to do with family guilt. So we all have families scattered all over God's green earth, and we're not capable of being there for family members when they need you. So you run into situations where you have to rely on whatever's happening at that location to be what it is. It's a lot more reassuring if you have something to go by that says, this institution or this group has full disclosure or whatever, rather than.
It's reassuring. So you're saying it's reassuring to the family to know that the institution is committed to full disclosure.
Right.
Right.
Puts a lot less guilt on the family in general.
Right.
To have that.
That's a good point. And I don't know that, I don't really know how University of Michigan, for example, advertises this. I think in part this study was more a response to the situation. It's not like they were sort of advertising to families that we have this process in place, but when the situation arose, then they would offer, they would disclose and offer compensation.
Right.
But you're making a.
You can't shop around at that stage of the game.
Right.
You have to go with the institutes.
Right.
Know at the time.
It may be actually a positive marketing point for institutions, actually. It's interesting. Good.
Any other questions? Thank you very much.
Thank you.